Now I'd like to talk to you about Crohn's disease, which is an inflammatory bowel disease. It has a peak incidence between 15 and 30 years with a strong family history of roughly 30 times more likely if a first sibling is affected. And it's been found to be linked to the NOD2 gene deletion, and is also a T-cell autoimmune mediated response. Its typical question will read more pain and weight loss, also systemically signs of unwell, sepsis, might have pyrexia, and also symptoms of malabsorption, which mainly in question format will be weight loss. The first thing to really understand about Crohn's is it's a transmural disease, which means it goes all the way through the bowel muscular wall. And if you understand that, you can understand what it can do. You can fistulate. It can form strictures and abscesses and also form collections. And this is exactly what UC doesn't do, as UC just affects the mucosa. Crohn's will go all the way through. And if you ever see fistulas and strictures, then you know that the most likely diagnosis is going to be Crohn's. If you have a bowel biopsy, you'll find that it's a non-caseating granulomas, and if this is in the EMQ, then this is pathognomonic of Crohn's. The other thing to note is that it's a mouth-to-anus illness which can affect anywhere along the digestive tract, and it has skipped lesions and cobblestoning effect. And cobblestoning means that small areas are affected, and then there's an unaffected area of bowels. And this is, again, directly opposite to UC, which is confined to the large bowel and has a continuous pattern to it. So the systemic symptoms that you'll get with Crohn's is anemia, which will be typically megablastic in form because it's a vitamin B12 deficiency. And this is linked to the fact that most of the vitamin B12 you'll remember is absorbed in the terminal ileum, and the terminal ileum is affected in 80% of Crohn's. Its old name used to be terminal ileitis before it was found in other parts of the bowel as well. Remembering that it affects mainly the terminal ileum, you'll note this is responsible for bile salt recycling. The bile salts are made in the liver, stored in the gallbladder, and then put into the second part of the duodenum. They're then reabsorbed in the terminal ileum, and if they're not reabsorbed, then your bile salts concentrations will decrease, and this means that fats will not be able to be adequately emulsified, and when this happens, you get cholesterol-based stones, and you're more likely to have gallstones. Uveitis in the eye, and that needs screening for, and arthritis, they are at risk of getting ankylosing spondylitis. Obviously this is more common in UC, but they are also at risk of getting it in Crohn's disease as well. And to note, skin, pyoderma gangrenosum and erythema nodosum will also be manifestations in about roughly less than 5% of people with Crohn's disease. And they do have an increased risk of malignancy. Anything with a constant inflammatory process in the bowel will cause that. And it's recommended that if you've had Crohn's for over 8 years, you should then continue to have surveillance follow-up. The likelihood is less than in UC, but it's still a risk nevertheless. Treatment options, if asked about first-line treatments, if anyone is septic, antibiotics should be used as first line. Steroids are also used in the short term, and that's prednisolone, used to treat acute flares, but in the long term it's got too many side effects to be used effectively. And the new drugs, which are 5-ASA, mesalazine and sulfasalazine. Sulfasalazine is mesalazine with an added sulfidine base unit to it, and this means that it has a larger availability by the time it reaches the bowel. Azathioprine affects purine, antimetabolite, and it's used as in DNA suppression. This means that anything that's dividing rapidly, such as T cells, will be affected, but it also has the problem that it can cause bone marrow suppression as one of its side effects. And infliximab is a monoclonal antibody to TNF-alpha. TNF-alpha is a potent pro-inflammatory cytokine, and it's used to mop up any TNF-alpha that remains in the serum. And finally, surgery can be used, and this is used as a last resort, as the recurrence is up to 30% once small bits of bowel have been removed. It's important to note that since it can affect anywhere and has skip lesions, you want to preserve as much bowel as possible with each operation. And this is, again, in direct contrast to UC, when removing the whole large colon will be curative. In Crohn's, unfortunately, it is not curative.